Mechanical ventilation is a life-saving intervention used when the respiratory system fails to maintain adequate gas exchange. Invasive mechanical ventilation is initiated after careful case-by-case assessment of clinical need. Indications include apnea, impending respiratory arrest, or severe respiratory distress with acidosis. It is also required in hypoxemic respiratory failure, not responding to high fraction of inspired oxygen. Airway protection is a key indication in patients with low Glasgow Coma Scale or copious secretions. Neuromuscular disease with declining vital capacity below 10 to 15 milliliters per kilogram also requires ventilation. Initial ventilator settings are based on predicted body weight calculated from patient height. Assist control mode is commonly used with either volume control or pressure control, depending on preference. Tidal volume is set at 6 milliliters per kilogram predicted body weight to prevent lung injury. Respiratory rate is adjusted based on minute ventilation and disease type such as obstructive lung disease. Fraction of inspired oxygen is initially set to 100% and titrated to maintain adequate oxygenation. Positive end expiratory pressure is started at 5 centimeters of water to prevent alveolar collapse. Inspiratory to expiratory ratio is usually set at 1:2 and adjusted based on oxygenation or carbon dioxide clearance. Monitoring includes maintaining plateau pressure below 30 centimeters of water to avoid barotrauma. Driving pressure should be kept below 14 centimeters of water to minimize lung injury. Ventilator waveforms help detect resistance, compliance issues, and patient ventilator asynchrony. Carbon dioxide levels are controlled by adjusting respiratory rate with permissive hypercapnia acceptable if pH remains above 7.2. Positive pressure ventilation can reduce blood pressure by decreasing venous return. Weaning begins when the underlying disease improves and the patient maintains adequate oxygenation and ventilation. Objective criteria include oxygen saturation above 90% with low ventilator support and stable hemodynamics. Rapid shallow breathing index less than 105 predicts successful weaning. A spontaneous breathing trial is conducted daily using low pressure support for 30 minutes to 2 hours. Successful trial requires stable oxygenation, respiratory rate below 35 per minute, and no signs of distress. Extubation requires a strong cough and ability to protect the airway. Non-invasive ventilation is useful in chronic obstructive pulmonary disease exacerbations and cardiogenic pulmonary edema. Positive pressure ventilation improves oxygenation by keeping alveoli open, but excessive pressure can cause lung injury. Complications include pneumothorax, pneumomediastinum, and ventilator-associated pneumonia. Ventilator-associated pneumonia occurs after 48 hours and carries high mortality. Common pathogens include Staphylococcus aureus and Pseudomonas aeruginosa, requiring broad-spectrum antibiotics. Prevention includes head elevation, hand hygiene, and minimizing sedation and circuit changes. Other complications include gastrointestinal bleeding, deep vein thrombosis, delirium, and muscle weakness. Extracorporeal membrane oxygenation is used in refractory hypoxemia or severe respiratory failure. Venovenous extracorporeal membrane oxygenation supports gas exchange while venarterial supports both heart and lungs. Complications of extracorporeal support include bleeding, infection, and vascular injury. Mechanical ventilation is a supportive therapy aimed at maintaining gas exchange while treating the underlying disease. The key principle is to use lung protective strategies while avoiding both underinflation and overdistension. Timely initiation, careful monitoring, and early liberation are essential to improve outcomes in critically ill patients.